So what's the reality as we go through it? It's a quote that I particularly like, that change is exhilarating when it's done by us and very exasperating when it's done to us. And I think a lot of us as we go through, especially as we look at health reform as employers, as healthcare providers, are actually just citizens. We kind of feel like this one was done to us, and there perhaps wasn't a voice as we came through that. And the opportunity, though, still exists for all of us to participate in that. One of my favorite Americans, Colin Powell, basically says you need to know your reality as we go through. And I think that's what, as healthcare providers, we're looking at this as. And so I'm going to briefly just go through a few things this morning and certainly provide opportunity then if there's open questions, but you've got a great panel of experts that are going to add content and expand on Ross's comments this morning. So what is the current state of reality? This is kind of what we know. As Ross mentioned, our GDP, our healthcare spending as a percent of gross domestic product is in excess of 17%. It's not a sustainable rate, and we need to do something about it. The other known is we know the chronology of the reform dates. It's all laid out there, and in fact, Paul gave us a great exhibit this morning that really does give good detail on what everything takes effect. And the surprising point is it's going to take a number of years. The unknown as a healthcare provider, this is the one that probably is giving most concern to us, is in this 2,700-page plus bill you've got sitting here, there are over 1,000 references that simply say the Secretary will determine, meaning they didn't put in the legislation how we were going to enact certain things related to cost reform, to payment reform, even insurance reform, employer mandates, other things. And so in most cases, the Secretary, meaning the Secretary of Health and Human Services and their staff, from an administrative perspective, need to determine the intent or the congressional intent in the law. Again, over 1,000 of those need to be addressed. That's why we're talking about an up to 10-year timeline in some cases, but certainly a multiple-year timeline before this can get enacted, because the intent was to get a bill passed. Now we have to figure out how to make it work or how to operationalize it as it goes through. And again, a number of those things, of those 1,000 plus, really deal with things that impact us on the health care delivery side and looking at payment reform and how we need to continue to work to improve and refine our health care systems. And of course, the biggest one is, as we go through, the known reality is we've got several elections coming through. And as Ross mentioned, will the bill change? Definitely. There'll be changes as it will evolve. We've got, the House is going to be up twice before the 2014 provisions kick into place. 2/3 of the Senate will be up for re-election, and then we'll have one presidential election between the time of full implementation of this bill. There is going to be a lot of turmoil, turnover, and really tumultuous discussion within Washington. And again, things that all of us in this room, either as individuals, as employers, as constituents of our elected officials, can have impact upon. So the reality with Innovis, really just a few things. One, we're an employer of over 2,500 employees. We're actually part of a regional health system, Essentia Health, that stretches from Wisconsin to Idaho with over 13,000 employees. And there's a number of things as an employer as are concerning to us. I mean, concerning, Ross pointed them out this morning, a number of those provisions and how we're going to react, what decisions we're going to make, what will change as we move to those implementation dates. And so, we interestingly, our colleagues here at Sanford Health Merit Care and us have multiple roles within this, because we're also healthcare providers, and certainly there's a lot of provisions in which we need to work and interact within that. But the one main one is we're both large, significant employers in the region, and so that does impact us as well as we go forward. Secondly, we're also, as I mentioned, healthcare providers, and as that, we're part of the problem. We definitely need to be part of the solution. And so as we look forward, we need to kind of glean through all this and determine, what are those key measures that truly will, in Ross's reference, bend the cost curve, but more importantly, ensure that we're delivering great, high-quality care with improved access or continued access to our patients across our region and our communities that we serve. The other part of that is, guess what? You guys are all part of the problem, too. And that means you all need to be part of the solution. We can go into a discussion about how we as a country don't deal with healthcare events very well, as individuals, as family members, as the patient. We don't deal with death. We don't deal with end-of-life care. We have high expectations. And you know what? That's a good thing. We should, because we live in a country that has tremendous potential to deliver and lead in healthcare delivery, not only models, but care for the world. But with that, we have to balance also the realities of what's affordable, just like we do in our own budgets back home, in our homes. So, some things we're doing at Innovis, certainly, and again, I think this could be given for pretty much any health system in the country right at the moment. We need to focus on growth. We need to focus on where we can continue to provide that our commitment to local-based care delivery, high-quality care, patient access, and look at our regional relationships. We need to determine in working together, not always basically beating each other up as we go through, but working together, both on a local basis, on a regional basis, in rural communities, in urban markets, how best we can serve those populations. The other thing is certainly there can be no question about a focus on both patient quality and exceptional customer service. And I would tie to that as well. We need to ensure access that comes through the system. There's no economic provision in healthcare that basically says you have cost, quality, and access, and you can't have all three. So pick the two you can do, and that's kind of a mindset that has been in healthcare decades in the past. The reality is, going forward, we have to do all three. Care models must evolve, and that means how we deliver care and who's providing that to you. Certainly we have, in this region, our patients and communities experience a variety of care providers across the spectrum, certainly from physicians, from our credentialed providers like nurse practitioners and physician assistants, but we need to perpetuate and continue to evolve that care delivery model to include a medical home environment that really looks at that care being provided by the most appropriate individual with the most appropriate licensure to address timely the healthcare need of the patient. So that means enhanced interactions with therapy or support staff or nursing staff, LPN, RN, depending on licensure, as part of a care team working with those credentialed providers and physicians taking care of a population. Reality is it isn't the Marcus Welby approach that perhaps we all kind of grew up with and idealistically we think is the model. The reality is this is better. And you're going to see that as patients. You're going to see that with your families going forward as these models are embraced and rolled out. And the great part is our regional providers all are on board with those things. We also, though, need to continue to align our cost structures. Healthcare, at the end of the day, is a business. And for us at Innovis and at Essentia Health, our target is really to be reimbursed, to basically be a sustainable organization at Medicare reimbursement. Medicare tends to be our lowest payer, with the exception, of course, our charity care. But and so in looking at that, we must have a cost structure in place as we look to a continued evolution that seems, at least right at the moment, inevitable of a higher government intervention within healthcare. The reimbursement model reality tends to point to Medicare. I would equate that to that if you're in the hotel business and your rack rate is $100, it's living on $30 or $35 for every room you have, and that's the cost structure you have to work at. The old adage in healthcare, it's not what you bill, it's what you collect, because rack rate or bill charges really mean nothing in our industry. So what we have to do is exactly the same thing, or continue to do, as all of you have done, is ensure our cost structure is in place that gives us really what we call really a value equation at Innovis and at Essentia. And our value equation is quality plus service plus safety, all over cost efficiency, or basically efficient cost over time. All of those aspects have to be and are our commitment to our patients and to the communities that we serve. The last thing I'm going to touch on just briefly is really accountable care organization. It isn't a term Ross brought up, but one of the provisions within the healthcare legislation really is taking either healthcare organizations, integrated organizations like Sanford Health Medicare or Innovis Health or others, and basically making them quasi-insurance companies in some way. There's a number of evolutions within the Medicare provisions that basically move us away from the old traditional fee-for-service, basically paying for episodic care, into paying us for bundled care, paying us a bundled reimbursement. So it's important under an integrated care environment that really moves to that payment and reimbursement model, because we have all the stakeholders within our organizations from the continuum of care provision, whether that be outpatients and clinics, all through through inpatient, through outpatient services, treatments, diagnostic therapies, and such, within integrated structures. And so we think that is a good direction, and we're strong advocates of integrated healthcare systems as we move forward. I think you're going to see continued evolution and expansion and consolidation of those models.